Welcome back to the deep dive. Today we're doing something a little different. We're going to build really the ultimate masterclass in human biology.
That's the goal.
We're not just going to talk about what the immune system does right. We're using its most profound failures, the primary immunodeficiencies, to see how the whole machine works.
Right. Think of these patient cases not as, just tragedies, but as illuminated blueprints of the system.
I love that framing.
Our mission today is really focused, and it's educational. We're taking these complex clinical phenotypes, the symptoms you see in a patient, and we're translating them back to the exact molecular or cellular problem.
So for any medical student, or really anyone listening, understanding how the system breaks is the clearest way to master it.
Absolutely. It's the most robust framework there is.
And we've structured this deep dive to follow the lines of defense. We'll start with humoral immunity, the failure to make good antibodies.
Then we'll hit T-cell and combined failures, then innate immunity.
Before tackling the really fascinating flip side, the failure of self-regulation, autoimmunity.
Let's jump right in. Let's go to the B-cell factory. So imagine you have a young male patient, let's call our case Bill, and he keeps coming in with these severe pus-forming bacterial infections.
Pathogenetic organisms.
Exactly. And you notice a clear X-linked inheritance pattern. Now, the puzzle starts immediately. The genes for the antibodies themselves, immunoglobulins, they're on autosomal chromosomes.
So why would a defect on the X chromosome stop antibody production?
That's the question. And it's a beautiful one because it tells you the problem isn't the antibody gene.
It's the cell making the antibody.
Precisely. You do the analysis, and you find a complete absence of mature B cells in his blood. So some gene on the X chromosome has to be absolutely critical for B cells to even develop in the first place.
And this is X-linked agammaglobulinemia, XLA.
Yes. Caused by a defect in a specific enzyme, Bruton's tyrosine kinase, or BTK. BTK gives a crucial signal that lets a B cell precursor move from the pro-B cell stage to the pre-B cell stage. That all happens in the bone marrow.
So if that signal fails, the B cells are just stuck. They're arrested.
They're stuck. They never mature. They never leave the marrow, which means no B cells in the blood, no plasma cells, and virtually no circulating antibodies. No IgG, no IgA, no IgM.
Which explains perfectly why he's so susceptible to those pathogenic bacteria, the ones that need antibodies to tag them for destruction.
Right, for opsonization.
But there's a really important timeline here, isn't there? Bill wasn't sick from the day he was born.
That's a vital clinical clue. For the first 6, maybe 10 months of life, he was protected by passive immunity.
Maternal IgG that crossed the placenta.
Exactly. But once those maternal antibodies naturally decay, the baby's own defect is unmasked. And clinically, if this goes undiagnosed, the constant inflammation from these infections, especially in the lungs, causes irreversible damage.
Bronchiectasis.
Yes, chronic lung disease.
Okay, so that's a failure of B cells to even mature. What happens if they mature just fine, but then they get stuck?
Yeah.
Stuck waiting for permission from T cells to become specialists.
Now you're talking about the hyper-IgM syndromes. So hyper-IgM means you can make IgM and IgD, but you failed to make the more specialized classes, IgG, IgA, or IgE. We can look at 2 different cases here to really understand the mechanism.
Okay.
First is X-linked hyper-IgM. This is actually a T-cell defect. The problem is something called CD40 ligand deficiency.
So the B cell needs help from the T cell to switch its antibody class.
It needs a very specific handshake. The activated T cell has to show the CD40 ligand on its surface, which then binds to a receptor, CD40, on the B cell. That interaction is the go signal to initiate class switching.
So without that ligand, the T cell just can't give the B cell the help it needs.
It can't. And what's fascinating here is that this T cell defect, it's not just about B cells, it also messes with the T cell's own activation and expansion.
So the T cells become broadly dysfunctional.
Yes, and that is why this version is so severe. It leads directly to opportunistic infections, which are the absolute hallmark of T cell failure. You see patients with terrible Cryptosporidium parvum infections.
Oh, that's nasty.
It is. It can lead to a fatal liver condition. Or you see severe pneumocystis pneumonia.
Now let's contrast that with the other case, activation-induced cynidine deaminase deficiency, AID deficiency. That one is autosomal recessive, so it's different already.
A completely different mechanism. Here, the T cells are fine. They express CD40 ligand. They provide the signal perfectly.
But the defect is inside the B cell.
Correct. The B cell is missing the enzyme, AID. This enzyme is what actually starts the DNA cutting and pasting process for both class switching and for somatic hypermutation.
Which is how antibodies get better and stronger over time.
Affinity maturation, yes. So the B cells get the signal, but they can't execute the command. They just pile up, stuck making IgM.
And because they're piling up.
You see a key distinguishing feature: hugely enlarged lymphoid organs. Splenomegaly, lymphadenopathy. You don't see that in the CD40 ligand defect.
And crucially, since their T cells are fine, they don't get those opportunistic infections.
Exactly. And that single clinical difference, the presence or absence of opportunistic infections, it's like an immunological fingerprint that points you directly to the molecular cause.
That is just an incredible level of precision.
Yeah.
Okay, let's shift gears now to the most severe category: T cell and combined immunodeficiencies, the SCID spectrum. Let's start with the classic X-linked SCID.
XSCID is really defined by what cells you're missing. You see a profound deficiency of T cells and NK cells, but you have normal, sometimes even high numbers of B lymphocytes.
The T minus NK minus B plus pattern.
That's the one. And the defect here is in a protein called the common gamma chain, or gamma key.
And that one protein is part of a whole bunch of different cytokine receptors, isn't it?
It is. It's the system's Achilles heel. The gamma chain is a shared component for the receptors for IL-2, IL-4, IL-7, IL-9, IL-15, and IL-21.
Wow.
But the two most critical ones here are IL-7, which is absolutely required for T cells to develop, and IL-15, which is required for NK cells. That one genetic defect perfectly explains why those two cell types are gone.
But the B cells, which use different signals, are spared.
They're spared, but they're non-functional without T cell help.
For anyone studying medicine, this specific defect comes with a massive clinical warning that you just can't overstate.
Live vaccines.
Never give them.
Never. An immunodeficient infant must never receive a live, attenuated viral vaccine. Without T-cell immunity, the weakened virus in the vaccine, say the old oral polio vaccine, can survive. It can mutate, and it can revert to a virulent form and cause paralytic polio.
It's just a catastrophic outcome.
It is, which is why newborn screening and rapid diagnosis are so vital.
Okay, so that's a complex signaling failure. How does that compare to something like DiGeorge syndrome, which is more of a structural problem?
That's a great way to put it. DiGeorge syndrome is usually caused by a small deletion on chromosome 22q11.2, and this deletion affects how the embryo develops, specifically the third and fourth pharyngeal pouches.
Which are the precursors for the thymus gland.
Exactly, and the parathyroid glands, too. So T-cell precursors are made just fine in the bone marrow, but they have nowhere to go to mature. The school for T-cells is missing, or it's rudimentary.
So no thymus, no T cells.
No functional T-cells, right. It results in profound T-cell lymphopenia, but the severity is on a spectrum.
Most cases are manageable, but the worst case is basically a SCID.
Yes, most patients have incomplete DiGeorge with a mild defect that can get better with age. But the very rare complete DiGeorge patient presents as a functional SCID and needs aggressive treatment, sometimes even a thymic transplant.
Amazing. Let's pivot now to the front lines. Innate immunity, specifically the phagocytes. Let's look at two critical problems: a failure to kill and a failure to move.
Starting with chronic granulomatous disease, or CGD, this is a failure of the phagocyte's internal killing machine.
The oxidative burst.
Right. The defect is in the NADPH oxidase enzyme, so neutrophils and macrophages can swallow microbes perfectly well, but they can't make the toxic reactive oxygen species like superoxide that are needed to actually destroy them.
So they lock the microbe up, but they can't throw away the key. How do you test for that in the lab?
The gold standard now is the DHR flow cytometry assay. You take the patient's neutrophils, you activate them, and you see if they can convert this chemical, dihydrotamine, into a fluorescent version.
Normal cells will light up.
Normal cells glow bright green on the flow cytometer. In CGD, they don't. The conversion fails.
And clinically, this failure to kill leads to the hallmark pathology, right? The granulomas.
Yes, this persistent intracellular infection leads to chronic granuloma formation, where the body just tries to wall off the infection it can't eliminate chemically.
Okay, so that's a killing defect. What about a mobility defect? Leukocyte adhesion deficiency, LAD.
LAD is fundamentally a movement disorder. It's caused by a deficiency in a protein subunit called CD18.
Which is part of the integrins, the molecular Velcro.
Perfect analogy. It's part of the beta-2 integrins, like LFA1 and MAC1. These are essential for leukocytes to stick to the inside of blood vessels and then squeeze through into the infected tissue.
So the cells are fine,
Yeah.
they just can't get out of the bloodstream to the site of injury.
They're trapped. And this leads to a very unique clinical sign.
A paradox in the lab results.
A huge paradox. You have these severe bacterial infections, but when you check the blood count, you find a pathologically high white blood cell count. Massive leukocytosis.
Tens of thousands of neutrophils just circulating aimlessly.
Because they're all stuck in the blood. Another classic sign is delayed separation of the umbilical cord stump, because you need neutrophils to migrate in for normal wound healing.
Okay, we've explored the defense failures. Now for the flip side, which is just as terrifying, when the system attacks the host. Let's start with autoinflammation.
It's a really vital concept. Autoinflammation is inflammation driven by the innate immune system running wild, specifically without self-reactive T cells or autoantibodies.
This isn't the adaptive system getting confused. It's the innate system's alarm bells being stuck in the on position.
Perfectly said. The best examples are the hereditary periodic fever syndromes like NOMID or SINCA.
And the cause is a mutation in a single gene that controls that alarm.
Exactly. In NOMID, you see mutations in the NLRP3 gene, which codes for a protein called cryopyrin. This protein is a key sensor in a big intracellular complex called the inflammasome.
And a mutation makes it hyperactive.
Constitutively active, it's always on, and the inflammasome's job is to be a molecular scissor that processes pro-IL-1 beta into its super-inflammatory active form.
So it's just churning out this powerful inflammatory cytokine nonstop.
Nonstop, driving systemic inflammation, fever, neutropenia, all without any infection or autoimmune trigger.
Now let's contrast that with adaptive autoimmunity, like rheumatoid arthritis, where the T and B cells are absolutely the culprits.
Right, and RA immediately tells you T cells are involved because there's a strong genetic association with specific MHC class II alleles.
Which implicates CD4 positive T cells.
It has to. The pathology is twofold. You have autoreactive CD4 T cells getting into the joints, activating macrophages, and driving inflammation. At the same time, you have autoreactive B cells producing autoantibodies like rheumatoid factor and anti-CCP.
And this detailed molecular understanding is what led directly to our modern biological therapies.
Absolutely. It's a triumph of translational medicine.
If you had to pick one of those therapies that really proves the central role of T cells in RA, what would it be?
I mean, TNF-alpha inhibitors are amazing. They block the downstream inflammation. But for me, it's abatacept.
The co-stimulation blocker.
Exactly. It's a fusion protein, CTLA-4Ig. It works by blocking signal 2, the necessary co-stimulatory signal that a T cell needs to become fully activated by an antigen-presenting cell.
So it's like a veto switch. The first signal happens, but the second one is blocked, and the whole inflammatory cascade just fizzles out before it starts.
Precisely. By blocking that step, we confirm that the whole chronic disease process is fundamentally dependent on T cell activation. It's a beautiful precision intervention.
This whole deep dive just keeps reinforcing one idea. Whether the failures is maturation like XLA, or signaling like SCID, or function like CDD, the clinical pattern you see is a direct map of the immune system's critical weak points.
It is. So, to pull this all together, let's do a little review exercise for anyone listening, especially the students.
Okay, let's do it.
We talked about X-linked agammaglobulinemia, XLA, which is a B cell defect, and we talked about leukocyte adhesion deficiency, LAD, a phagocyte defect. Both of them present with severe recurrent pyogenic infections.
Right, the same top-level clinical problem.
Yes. So the question is, explain the core immunological mechanism of failure in both XLA and LAD, and then detail why the absolute neutrophil count in the blood would be normal or low in XLA, but pathologically high in LAD.
That is a fantastic question. It connects the dots perfectly. Okay,
Right.
so the common symptom, pyogenic infection, happens for completely opposite reasons.
Yeah.
In XLA, the failure is humoral. The B cells can't mature, so you have no antibodies. The neutrophils are made just fine, but they're fighting with one hand tied behind their back. They don't have the antibody opsonization they need to clear bacteria efficiently.
And their count in the blood?
It would be normal, or maybe even low, because they're able to leave the circulation and go to the site of infection and get used up in the fight.
Perfect. And in LAD?
In LAD, the failure is cell migration. The neutrophils are made, they're ready to go, but they're missing the CD18 integrin. They can't stick to the blood vessel wall to get out.
So the infection site is?
Devoid of neutrophils, leading to a catastrophic infection. But because all those cells are physically trapped in the bloodstream, the lab result is that dramatic, sky-high leukocytosis. The defect is the traffic jam, not the car itself.
A perfect demonstration. You have to dig into the molecular mechanism to understand the cellular geography of the disease.
It also leaves us with one final kind of provocative thought. We've seen what happens when the defense system breaks down on its own, but the relationship between fighting invaders and maintaining self-tolerance is just incredibly fragile.
It really is. The immune system is constantly risking self-destruction in its fight for survival. You can see how an infectious agent could break tolerance, even just for a bit. It might expose self-antigens that are normally hidden, or it might have molecules that look a lot like our own molecules.
Molecular mimicry.
Exactly. A classic example is a mycoplasma infection, sometimes triggering the production of antibodies against the eye antigen on your own red blood cells, leading to autoimmune hemolytic anemia. The line between defense and self-attack isn't a wall, it's more like a tightly controlled gate that a clever pathogen can sometimes pry open.